This video demonstrates the extraction of a mandibular canine tooth using a mechanical periotome. And when you do this, you definitely want to do a flap, but you do not have to take as much bone. See how much we've removed, and we've got that little ledge that we've created with our crosscut tapered Fisher burr, probably about 70% less or 60% less bone than we would normally take, down to the middle foramen if we're not using this instrument. And then we make 2 passes on each half of what we estimate to be the path of that canine tooth. And based on the size of the patient, we'll estimate also how far down that we will go, not wanting to go past the apex, obviously. So you can see we've left plenty of room. This is a fairly large dog, about 80 pounds. We left plenty of room where we won't be taking that tip down to the apex. And you see how easy it was on that second pass. That first pass really opens up that entire area. And then when we go down here, you'll kind of see the same thing on the second pass here. And that one actually is going in very easily too. So this is a very efficient way to do extractions, especially of incisors, canine teeth, and in some cases a mandibular first molar, because all those teeth roots are flat relatively, and it makes it easy to get that periotome pass. Now there's 2 blades. This is the larger blade that I'm using for this dog. For small dogs and cats, you want to use a smaller blade, smaller width blade. And then all I'm going to do here is place my extraction forceps on here, torque a little bit. You can see the movement there already. Torque a little bit and pull. And generally, this will result in extraction of the tooth with the extraction forceps only. If it doesn't, you can certainly use an elevator to assist you. I generally use this on the highest setting. Their setting is from 1 to 10. And with the fact that we're using the periotome, we don't have to take as much bone, as I mentioned, and your surgical flap doesn't have to go back as far. Generally, I take it back to the middle part of the 3rd premolar, and when I use this, which is almost exclusively now, I'll go back to the end of the 2nd premolar, and that gives you plenty of room to make your vestibular bone removal in that little ledge in that coronal portion. I'd say maybe 20%, 25% at the most. If you're not doing a lot of dentistry, I wouldn't even consider this instrument. But if you are and you find yourself extracting a lot of fractured teeth that don't have perio, it comes in extremely handy there, as in this case. I also use it quite a bit in perio where there's not mobility. So total time for extraction from the initiation of the incision back to that 2nd premolar, including the vestibular bone removal. And I didn't mention we did do a groove down to that area that I ledged on the mesial and distal side of the tooth as well. We always do that. 9.5 minutes, so less than 2 minutes with the periotome.